Hello, and welcome to tonight's Immunisation Coalition webinar event. Our topic this evening is COVID-19 disease update. My name is Andrew Minton. I work for the Immunisation Coalition, and I'm fortunate enough to be your moderator tonight. I'm not COVID-19 expert. Our guest speaker tonight is Professor Gary Groman. So, and I've had a quick look through his presentation. It looks absolutely fabulous. So we're in for a treat. Before I start, just some housekeeping. I'd like to recite the welcome to country. I would like to acknowledge the traditional custodians of the various lands of which we work today, and welcome all Aboriginal and Torres Strait Islander peoples that may be participating in this webinar tonight. The Immunisation Coalition welcomes you. I pay my respects to elders past, present, and emerging, and in particular the Gadigal people of the Sydney area of which I reside. And celebrate the diversity of all Aboriginal peoples and their ongoing cultures and connections to the various animals, lands, and waters of Australia. Just before I introduce Professor Gary Groman, just to let you know that he will be speaking for about 40 minutes. That leaves us with about 15 minutes of Q&A time. Please add your questions in the bottom of the screen in the Q&A function. I'll be looking for those questions and I will do my best to look at those and provide those questions to Gary at the end of the presentation. Please feel free to use the chat. You may have comments or you may have questions that you might want feedback from your colleagues, but predominantly I'll be looking at the Q&A function box. This is a recorded event, therefore everyone will be on mute except myself and the presenter. And sorry, I just got a text message. It's dangerous to turn that off. If we're not able to get to your questions, we will have a record of those questions and we'll provide a transcript of answers to those questions and provide those as an EDM sometime next week, together with a link with the recorded presentation, which will be on our website. Currently, we have 184 people online. There's going to be probably another 150 who will join a little bit later. Before I introduce tonight's guest speaker, I'd just like to run through a few stats. I always like to do that, just to frame things and put things into context. So we're talking about COVID-19 year-to-date numbers. 2024, we have just over 128,000 laboratory confirmed cases, but we need to kind of refer that to either another disease area or another time. So if I look back at the same time, year to date 2023, there was just over 673,000 cases. So today is about a fifth of that. And if we go back one more year, well, we're in the millions. We're at 7.4 million. So those are kind of days gone by. So COVID-19 is still out and about. As I said, 128,000 cases. And if we compare that with, diseases that are more in the news these days than COVID-19, if we take influenza, and we're just at the start of the influenza season, year to date, 2024 nationally, it's not broken down by any age group or anything, 50,000 laboratory confirmed cases, and RSV at 64,000 cases. So the next couple of months will determine what sort of season we have with those two respiratory viruses. But again, 128,000 for COVID-19. So still a lot of cases. So just like to introduce our guest speaker, Professor Gary Groman. Gary is a board member and director of the Immunisation Coalition, as well as a member of the IC Scientific Advisory Committee. He is an adjunct professor at the University of Sydney and is a former head of immunology at the TGA. Gary is a virologist and a consultant for a number of organizations and companies, including the WHO, Environmental Pathogens PLC in Canberra, and BioIntellect. His interests include virology, vaccination control of infectious diseases, pandemic planning, particularly around COVID-19 and influenza, regulatory advice, of course, being a former member of the TGA, vaccine development and vaccine manufacturing. So without further ado, I'd like to hand over to you, Gary, to take us through your presentation on COVID-19 disease.
Thanks very much, Andrew, for the introduction and also for the invitation. A few disclosures. Recently had some advisory meetings only with World Health Organization, Seqirus, MSD, GPN, BioSelect, BioIntellect, mainly to do with pneumococcal, influenza, COVID, and Japanese encephalitis. So they're just some of the disclosures. Well, WHO has declared a few times now that the global emergency is over. So for 3 years now, since the pandemic began, there's been this drop in death rate pretty regularly after we had the third or fourth peak. And we can see there that WHO saw data where the death rate dropped from 100,000 a week down to 3,500 a week by April 2023. In the last 7 days, according to WHO, we've only had 382 deaths. But it does warn us not to let down our guard, not to dismantle any of the systems that we have built, and to keep up the message to everyone that COVID-19 vaccines are important, and also our restrictions and various things that we've done to stem the tide of COVID-19 are also still important. So what are we dealing with now? What we're dealing with is a steady state respiratory infection in the community. The virus has been mutating over time towards less severity. We've seen that month after month, wave after wave. So now we mostly have asymptomatic and quite mild infections. We have Omicron, JN1 lineage viruses predominating globally, and KP2 in the USA, which has now been detected in Australia, has risen to around about 25%. But ultimately, these are still all XBB viruses that are simply mutating and moving on in the dendrogram, in the genetic tree. It has been the case that many have catastrophized every time there's a new appearance of the virus, either in the press or on the internet and so on, and there's absolutely no need to do that. What we've seen is a tendency towards less severity, not more severity, which is the case for most viruses as they go through the human community. We know that vaccines are available and are important for those over 75 years. Health, and particularly health compromised people as well, we know they can be rapidly updated. We've seen the rise of hybrid immunity in the community. We've seen antiviral drugs that are very successful and now available. We've also seen home testing kits, which have been available and used widely. And in Australia, we could probably, unfortunately, still expect somewhere between 1,000 and 3,000 people a year to die from COVID-19. But the good news is, if there is good news in this, is that the death rate is in fact declining. We still have a lot of challenges remaining. The most obvious one is long COVID. But we also have a community that's rather blasé to booster vaccination. And that's resulted in a low vaccine uptake in the last 6 months. And I'll show you some data on that. We've also seen COVID rebound after the use of some antiviral drugs. We've seen damage to the health and education programs and economies and so on. We've seen vaccine injury and mandates and job income losses and resultant class actions. We've seen vaccine fatigue in that other vaccine programs have been affected as well, although there's a little rebound from that. We've seen distrust, we've seen fear, and unfortunately a lot of disinformation. And this has really provided a tremendous challenge, which I imagine is going to be ongoing for years. What do we need? We certainly need better vaccines, we need more antivirals, and we also need other drugs to combat infections like this. What about WHO? What are they showing at the moment? In terms of cases, they're showing 775 million cases globally, but this, of course, is entirely underreported. But nevertheless, the number of cases have certainly dropped, and we've seen the whole world go through these various waves, 6 or 7 of them, whichever way you want to interpret the graph. And WHO have also shown a number of deaths, over 7 million deaths, at least since April, until April, I should say. It gives us a case fatality rate of 0.91, but that, of course, is entirely inaccurate, as the number of cases is, in fact, much higher, although the number of deaths is probably reasonably accurate, although it can never be perfect. the case fatality rate is almost certainly something like 0.09 or less. We look at further global data from various countries, France, United States, Canada, Germany, India, UK. We've seen the death rate has dropped there markedly as well, and that's from our world data. What about Australia? We've had 25,000 deaths or so, 11 million cases reported. Again, the case fatality rate isn't accurate, and it's probably more like less than 0.09. In fact, influenza, just by comparison, is around about 0.09, and I expect it to be more or less the same. Again, we've seen the number of cases drop over time, as well as the number of deaths that have been reported to WHO. And for all these reasons, the WHO has decided that this virus doesn't rate anymore as a public health emergency of international concern. But we haven't done so well with our First Nations people, Aboriginal and Torres Strait Islanders. If you look at death rates per 100,000 people, on the left, you see the rates here for Indigenous in various age groups. Sorry for that. And on the right, we're seeing non-Indigenous, which is half or much less. And depending on the age group, our Indigenous groups tend to suffer 2, 3, 4, even 5 times more in terms of cases and deaths. What about excess deaths is another way to look at what's happening around the world rather than looking at CFR. And if we look at excess deaths, we see it's pretty bad there in Russia and India, over 1,000 in Russia, 500 for India, 400 in the USA, nearly 400 in the UK. Sweden, which is really the elephant in the room because they didn't really have the restrictions that everybody else put on around the world, but they only had 226. Australia fared incredibly well with only 131. So from an epidemiological point of view, we know it's spread by respiratory droplets. It's not, the earlier reports of it being spread by pizza boxes and footballs and fomites and on surfaces and so on are really totally exaggerated. This is a respiratory virus spread by respiratory disease, and hand, mouth, eyes, nose, and fomites. Yes, the R number 5 to 6, much greater than flu, but not as bad as something like measles. The virus is easily destroyed, in fact, in the environment and by chemicals. Masks we found were in fact quite effective if properly used. The evidence in the beginning was a little bit thin, but clearly it's masks together with hygiene measures have been incredibly effective. Sweden was less effective than anybody else, most comparable countries anyway, that implemented stricter lockdowns, and that might be worth studying, I would suggest, for our next pandemic and what plans we have for that. And I think we need to look at Sweden there. And hygiene measures and isolation have been incredibly effective together with masks, as we know. And the evidence for that is quite nice on this graph. This is Australian COVID death data. We see that here's our first wave, and there were restrictions put on, and rightly so, for quite some time. In some states quite severe, in others not so severe. Then vaccines were rolled out and restrictions were lifted here on October 21. And of course, we knew the vaccines wouldn't particularly stop the spread of virus, although they did halt the death rate markedly and definitely save lives. But once the restrictions went, the virus started to go. So there is great value in these restrictions if they're properly managed. And it's very, very important that we look at this data and try and understand what happened in the past. What about the virus itself? Well, it's changing all the time. I mentioned before, KP2 is now emerging. It's really a JN virus anyway. And this is all virological talk, which not everybody will understand or even be interested in. But the XBB is what our current monovalent is. So it's the XBB group that comprises this JN1 and now the KP2. So our vaccines will still be around about 60 to 70% effective in terms of ameliorating the death rate and severe disease and the hospitalization rate. But again, there's no need to catastrophize these things as people tend to do. It's quite important to understand there will be point mutations, and every time the virus is seeded into another country and moves around and goes to a variety of groups, particularly the medically compromised, there will be new viruses emerging. What about vaccine coverage? We see we've done incredibly well around the world thanks to the miracle of messenger RNA virus vaccines, messenger RNA vaccines, I should say, and also the AstraZeneca vaccine, which were predominantly used in the beginning. Globally, nearly 14 billion vaccines, probably hit that now. In Australia, 71 million doses of vaccine. So 2/3 of the globe completing the primary series, 32% with one booster. And in Australia, I think we did quite well. 85% was really quite extraordinary, with 56% getting a third dose, and then 44% at least another booster. But again, with other groups who didn't do so well, Australia-wide, our over 75s who got a booster in the last 6 months, less than 40%, 65 to 74, just 25%, and 18 to 64, just 3.9%. So people are certainly clearly losing interest in getting a booster. Aged care residents, 43%, so that's quite low really, should be a lot more. And again, we've dropped the ball in many ways with our Aboriginal and Torres Strait Islander people, only 11%. And again, mistrust there. And we did reasonably well with those that are disabled, the NDIS group, getting 26% who have had a boost in the last 6 months. It's still important that we get those in critical care or those more susceptible to make sure that they get their boosters every 6 to 12 months. What about seroprevalence? Nearly everybody around the world's had the virus or had the vaccine. So the global seroprevalence is estimated by WHO at about 59.2%. But of course, true infections of COVID around the world far exceeded the reported cases. You can see there in the UK, approaching 80%, in Italy, over 85%, in Australia, 98%. And at least 64% of our 19-year-olds, 64% of our 19-year-olds and under have been infected with the virus, looking at nuclear capsid antibodies that signify past infection. There's some nice work done by the Kirby and also by NCIRS on blood donors. To start with, you can see anti-spike antibodies there, and also the anti-nuclear capsid seroprevalence was high in blood donors, highest in Queensland. And for children and adolescents, at least 65% of those under 19 have got spike antibodies and also nuclear capsid antibodies. So what about vaccines? What do we have? We know that the vaccination platforms we've been using in Australia in particular were the messenger RNA vaccines and viral vectored vaccines and recombinant protein vaccines. And they've very impressive efficacy and safety on phase 3 trials. But the WHO did make this comment very early on that the necessity and risk benefit of continuously administering booster doses of mRNA to healthy individuals under 50 was really uncertain. There was this issue of myocarditis, but also the virus was changing, becoming less severe. And so WHO and others have concluded, well, maybe there isn't a great need for people under 50 to get the vaccine, but we'll come back to that point. Clearly, there's a kind of tipping point. We will get to a tipping point that as people become infected and vaccinated together with favourable viral mutation leading to less severity, then COVID-19 will certainly become less important to the non-risk groups in the community, but they will always be important to the risk groups in the community. And we have to keep making that point. So what vaccines do we have? We have mRNA vaccine, the Pfizer one for 5 to under 12. We also have the Pfizer and Moderna vaccines available as adolescent and adult formulations with the XBB monovalent vaccine. And of course, we learned a big lesson there about imprinting and why it's important to have monovalent vaccines, at least for many viruses. Otherwise, you get this problem of imprinting and boosting of ancestral strains, which isn't useful as opposed to the strain that you want to target. So that happened, and hence WHO decided that we must go to monovalent vaccines, and rightly so. We've had Novavax vaccines in the past, but they're not registered at the moment. They're still going through the process of registration of the XBB 1.5 strain, the monovalent strain, but that will come in due course. What about ATAGI? ATAGI's recommendations have changed yet again, and it's necessary as more data comes online. But we can see that for those that are immunocompromised, it's recommended every 6 months. For the over 75s, for 65 to 74, every 12 months. You can consider it every 6. 18 to 64, every 12 months, and again, consider every 6. For 5 to 17, it can be considered every 12 months and not recommended for the under 5s. And for those without any severe conditions, it's certainly recommended for the over 75s, recommended every 12 months for 65 to 74, only a consider for 18 to 64, not recommended for under 17. So to summarize it a little bit, it's important that everyone over 75 and those in high-risk groups get vaccinated and take boosters around every 6 months. It's a message that's been going out there for a long while, but with only a 39% uptake in some of the highest risk groups of boosters, we're not doing so well. And that clearly it's the high risk groups that will gain the most from receiving a COVID-19 booster. So vaccines for the vulnerable, masks and sensible social distancing, hygiene measures, continuing education programs are still very important in our post-pandemic response. It would be a pity if we fell into apathy about all this and then we had surges of virus, particularly in our vulnerable communities. People in high risk groups, including older adults, people with immune problems, really should get the vaccine every 6 months. So who are the medically compromised? Why is it recommended there? It's recommended for anyone with an immunocompromising condition, cardiac disease, chronic respiratory, neurological or metabolic condition, chronic kidney disease, hematological disorders, chromosomal abnormalities, and people that are obese. It's also recommended in pregnancy. So unvaccinated pregnant women we know are at increased risk of severe disease from COVID-19. It's recommended they receive a primary course of COVID-19. The latest monovalent XBB is a booster. Interestingly, the mRNA COVID-19 vaccines actually haven't been formally studied in pregnant women, but ATAGI and the TGA consider them safe for use based on previous data. That's not unusual, and there's been no issues in terms of adverse reactions that have been reported. Also, that women who are breastfeeding can receive COVID-19 vaccine at any time. TGA reports of adverse reactions have been incredibly low. In fact, they've been dropping over time. Only 2 per 1,000 doses have been reported to the TGA. None of them have been particularly serious, particularly recently, and various numbers there that you can see for the different vaccines. But that is incredibly low, although not many people may know that you can report to the TGA or other groups, but the TGA will continue to get those adverse reactions and investigate them if they're serious. So what are some of the adverse events? For the mRNA, irritability, drowsiness, injection site tenderness, and so on, all minor, sometimes headache, loss of appetite, muscle pain. For anaphylaxis, around 10 per million, 1 in 100,000. For myocarditis, more or less the same, incredibly rare. But the highest incidence has been reported in adolescent males after a second shot. For the protein vaccine, there's similar minor adverse reactions that occur, and again, they occur in a similar frequency to adolescents. For anaphylaxis, it's really undetermined, but it seems to me it's less than 10 per million, so incredibly rare. And for myocarditis or pericarditis, it certainly exists, but again, very rare, with a very low incidence of myocarditis. And there is some pericarditis, but again, you're talking 10 per million, around about that number. So much has been made of these adverse events, but they're very, very rare, and clearly on any risk assessment, you would favour taking the vaccine to avoid serious disease, particularly if you're in a risk group. Just a note on anaphylaxis, it's if anybody's had anaphylaxis after an mRNA vaccine, then it's a contraindication to have another one. And for the mRNA vaccines, again, it's polyethylene glycol that people might have an adverse reaction to. For Nuvaxoid, polysorbate 80, some people might have a reaction to. But again, these things are incredibly rare. So to summarize the vaccine part at least, current vaccines do not stop transmission. They do ameliorate severity. Heterologous vaccination, 2 different vaccines, gives a better immune response. Hybrid vaccination gives the best, a vaccine plus the natural infection. Adverse events incredibly rare. AstraZeneca vaccine has now been withdrawn from the market, not used in Australia for some time and withdrawn now in the EU. They did have some rare blood clot issues, TTS, and possibly an increased GBS signal, but I think that's unlikely looking at the data, but it's a suggestion. In any event, the vaccine's been withdrawn, and it was a very, very important part in the early days of our response globally, but in particular in Australia and the UK. The protein vaccine does seem to have a lower risk of myocarditis. It's not registered yet in Australia. The new one, as I mentioned, but it should be on board soon. So what about vaccine platforms? We have currently mRNA and recombinant protein with their very impressive efficacy and safety. The protein vaccines offer some advantages. They can be preferred. If they're preferred, they can be used as a booster. The more vaccine providers we have, the better. So hopefully it will come online. And also it's a little bit easier in terms of transport and distribution. Self-amplified RNA is on the horizon. In Japan, this vaccine has been approved. It's a collaboration between Arcturus and CSL, and we'll see if it comes to Australia or elsewhere, and looking forward to the safety data and efficacy data on that for real world. How does it work? Just in simple terms, we know the synthetic mRNA gets translated into protein antigen and then an immune response. For self-amplifying, there are more pieces of RNA that are produced, so therefore you're going to get more protein antigen and presumably an amplified immune response. So that's the idea, and it seems to be working quite well. It's being registered, as I mentioned, in Japan, and we'll see where it goes from there. Are there other platforms being looked at? A lot. So, you find, I think it's 181 or something platforms in total, and most of them are protein subunit and RNA platforms, but there are others, viral vectors, DNA, inactivated virus, live virus, and so on, and people looking at various platforms to see if they can make a better vaccine. Most of these are in phase 1 or 2 studies, a few in phase 3. So we look forward to those to see what they can produce. So let's look at the symptoms of COVID-19. We know that the symptoms may appear between 2 and 14 days after exposure to the virus, and anyone can have mild to severe symptoms or asymptomatic, or be asymptomatic. If you're symptomatic, then fever or chills, cough, shortness of breath, fatigue, muscle, pain, headache, loss of taste and smell, sore throat, congestion or runny nose and nausea are the most common symptoms that are described, but there are over 200 symptoms described. These are just the most common. But there are some emergency warning signs that are worth considering: trouble breathing, persistent pain or pressure in the chest, new confusion, an inability to wake or stay awake, pale grey, blue-coloured skin, lips or nail beds, depending on skin tone. And in children, we do see this multi-system inflammatory disease, an unusual presentation similar to Kawasaki disease, incredibly rare, but it involves hypertension, a non-parallel conjunctivitis, polymorphic rash, mucosal changes, and swollen extremities. It's good to remember that SARS-CoV-2, the virus causing COVID-19, is a neurotropic virus. And in fact, 10 to 15% of patients, according to USA data, develop acute neurological symptoms. They're often associated with forms of stroke, neuroinflammatory disorders or meningitis or encephalitis. And less frequently, we see peripheral nerve involvement, muscle weakness or GBS. The clinical course is becoming clearer. There are 3 phases: pre-symptomatic, symptomatic, and recovery. We can see PCR and rat tests can be quite useful in this period here of being symptomatic. The virus replicates, as most viruses do, before the onset of symptoms. Then we get the innate immune response and then humoral and cellular immune responses. But if these are weak, then it can translate into severe disease as opposed to mild disease. And then there's a recovery phase. And depending on the immune system of the person and their illnesses and so on, some people can have significant sequelae. Many have poor neutralizing antibody. Antibody wanes, leading to reinfection. And some people get, excuse me, long COVID or post-COVID syndrome. So long COVID has now been well described, and it basically consists of three major disorders: chronic inflammation, immune dysfunction, and microthrombosis, affecting the brain, especially lung, cardiovascular, and also the GI tract. Definition is difficult. It's defined by WHO and a number of other groups as the continuation or new or development of new symptoms going beyond 3 months. Depending on the data you read, it would seem that 10 to 20% of people are affected. Certainly more than 50 million people across the EU are affected, and over 20 million in the USA. I'm not sure how many in Australia, but I suspect it's around about 1 million. There's been quite a nice review done by the Australian Institute of Health and Welfare. They have decided this between 5 and 10% of COVID cases go on for more than 3 months, but the vast majority resolve within 9 to 12 months spontaneously. But there are some key risk factors they identified: severity of illness, comorbidities, female gender, mid-adult age group. These were the main risk factors that they identified. And interestingly, they were one of the first to identify that having 2 doses of vaccine actually lowered the risk of symptoms persisting beyond 4 weeks. They estimated it as 13 to 47% on their analysis of various papers, and it'd be interesting to see better data on that to see how true this is. But I suspect it is the case, and it is a very good argument to continue vaccination and boosters, particularly for young people who might have now become far more blasé about it. Long COVID is difficult. As I said, there are over 200 symptoms described, and it has various names in the literature that I've put up there in blue. So anyone who gets COVID can have long COVID. And of course, the only way to avoid it is not to get COVID in the first place. But the most commonly reported symptoms are fatigue, symptoms that get worse after any effort, recurrent fever, and shortness of breath and cough. More rarely, neurological symptoms: dizziness, headache, pins and needles, depression, and joint and muscle pain, heart symptoms, including POTS, cardiac disorders, digestive symptoms, blood clots, rash, changes in the menstrual cycle, reactivation of various viruses, particularly herpes, leading to shingles, GBS, and Bell's palsy. And there are long-term effects, and we now know that there is organ damage. There can be long-term inflammation and even new conditions such as diabetes, heart or nervous system disorders, and multi-system inflammatory syndromes as well. Some interesting research that's been done looking at brain abnormalities 6 months after symptoms have so-called gone, and they've noticed changes to the brain stem, frontal lobe areas of the brain associated with fatigue, insomnia, anxiety, depression, so on. And this has been done using a special MRI to detect and monitor these conditions, and particularly microbleeds, vascular malformation, brain tumors, and stroke that are all associated with long COVID condition. Not for everyone, just for some people. So there are some interesting biomarkers that have appeared. Right. So elevated inflammatory markers, we've seen interleukin-6, C-reactive protein, TNF, and also a number of blood biomarkers, and in particular complement, that certainly worth looking at. And although there's nothing that's been set down in stone, but there's some interesting evidence from murine studies on MERS, which has identified the complement activation system could be a key contributor to COVID pathogenesis. And we'll have to just watch this space for that. And with regard to complement, it looks like there's dysregulation of immune responses, as well as a complement and coagulation pathways that's leading to inflammation. So this might actually be used not only as a way to treat patients, but also as a way to diagnose them. So patients have demonstrated activation of the complement pathway, particular C3, C5b9, which were associated with poor prognosis, respiratory failure, and it's probably due to a blockade of the specific complement pathway. And so it could be a potential therapeutic for COVID-19. So there've been C5 and C3 inhibitors used for treatment in some patients with moderate success. So again, it's a watch this space. Normal antiviral treatments are, of course, antivirals, which are used for both COVID-19 and also for long COVID. But for Paxlovid, which is available, and molnupiravir as well, there are eligibility criteria, 70 years and over or 50 years with additional risk factors, any First Nations person over 30, 18 years and older with moderately to severe immunocompromised condition. Molnupiravir can also be used, simnotrilivir as well, can shorten symptoms for people with mild infections. It's a protease inhibitor. But in red there, all antivirals have contraindications, and the TGA has listed quite a few. So it's really, really important that patients talk to their GPs about the use of these drugs. But it's drugs are really the way forward in terms of treatment at the moment, and we're all hoping that there'll be more breakthroughs on the drug side to help treat people with long COVID and severe COVID as well. Monoclonal antibodies have also been used with great success. I don't know of any that have been registered, but there's certainly, at least not in Australia, but there's certainly quite a lot that have been used around the world. So both antivirals have been associated with a lower all-cause mortality risk. And we know that Paxlovid is authorized for use in children under 12, but molnupiravir is not. And molnupiravir is not recommended for pregnant individuals because animal studies suggest it could cause fetal harm. What about COVID rebound? So this happens when people are taking Paxlovid and it appears to resolve, but is mild and short-lived, and then in 3 days, without any additional treatment, it rebounds. And this is because of the ritonavir. It can slow the metabolism of an assortment of other drugs that are then increasing the concentration of blood, and then you get these drug interactions, which can be managed by temporarily withholding them and adjusting the dose or using an alternative to the concomitant medication. So again, that's one of the reasons that a patient needs to absolutely be in touch with their GP about what might be appropriate treatment. Just very briefly, another thing we need to manage in our post-COVID era are vaccine mandates. Unfortunately, there's now, mandates were not the right way to go. The WHO said at the beginning that vaccine mandates are actually a violation of human rights. And that's gone to a number of courts around the world. And now there's a case in Queensland where people were stood down simply because they hadn't had the vaccine. So there'll be some landmark cases there to keep an eye out on. And also vaccine injury we need to manage. There are a number of class actions. And the federal government, I think very rightly, has implicated a claim scheme for people who suffer moderately or severely from these impacts from a TGA-approved vaccine. I think that's been a positive step forward. So some concluding remarks. There is no clear explanation why COVID-19 can result in severe outcomes or death, while other coronaviruses just cause a common cold, or why COVID-19 symptoms persist after infection, even after the virus has been eliminated. Using artificial intelligence, there's some interesting work going on at UCLA that has shown that fragments of the coronavirus may drive inflammation by mimicking the action of specific immune molecules in the body. We know viral protein fragments generated after infection are broken down into pieces, and these can mimic key components of the body's machinery and may amplify immune signals. So that's the direction where research is going in this area. I think it's quite exciting, and we'll see what it brings. Just some final remarks then. It seems to me, at least, that we do need better vaccines. We always have since the beginning, despite the fact they've been miraculous and saved so many lives. But if we're going to convince people to take these vaccines, then we have to have better vaccines, ideally to stop transmission, which we don't have at the moment. And the most successful platforms today are the mRNA and recombinant protein. Self-amplifying RNA, we'll just have to see how that goes. And clearly, COVID vaccines must gain acceptance, and really in a way that must gain re-acceptance. We must hopefully vaccinate a vulnerable population annually and biannually for those at high risk. We have to avoid this cycle of neglect, and I think we're drifting into it, unfortunately, and we have to have continuous pandemic preparedness. Long COVID is a major challenge, as is vaccine injury. The use of monoclonal antibodies, I hope, will come to the fore, better antiviral drugs, and we have this threat now, multiple respiratory agents. Since COVID has come and gone, so to speak, we've seen and really eliminated the B. Yamagata strain of influenza, and many other viruses temporarily disappeared, but now, of course, they're on a resurgence, particularly flu and RSV. COVID-19's gone down, but there'll be other viruses that will come up now, and we need to be alert to those as well of this multiple threat. Thank you. A few acknowledgements there. Various groups who have given me information or taken information, and I'm happy to take any questions. Thank you, Andrew.
Thanks, Gary. Fabulous overview. So there's been a lot of questions. I'll go through them and some comments as well, but I'll just start off by asking, you know, in the early years of COVID-19, the public was driven to providers. Now there's more emphasis now on flu and RSV because we're in the season and there's new monoclonal antibodies and new vaccines for RSV. Do you think now that the onus is on healthcare professionals, where the public is coming into a clinic, a GP practice or a pharmacy, for them to start screening whether or not patients of a particular age, for example, they screen them to ask them whether or not they've had their COVID-19 if they're coming in for their flu?
Sure. Not only flu and COVID, which are really important at this time, but really any vaccine. So many people, particularly children, missed out on the NIP in a way of getting their regular doses. But we have to keep reminding adults as well the vaccines are available. Shingles, for example, for the over 70s, influenza for everybody, COVID vaccine, depending on age appropriateness and also concomitant illnesses and so on, how susceptible you are. It's really important to keep it up, in my view, for every vaccine. So when children come in or parents come in or adults come in for their vaccination or checkup, they do get asked about their vaccination status. And especially for travellers or people taking holidays and so on, it's simply common sense to make sure that all your vaccines are up to date, absolutely all of them. And that might take a bit of planning, particularly if you need a booster to whooping cough or something like that, depending. So it's really important, I think, that health providers keep reminding patients that vaccines are important. We have to keep up the fight. And of course, I'm totally biased being a board member of the Immunisation Coalition, but I think it's absolutely essential.
Thank you. Yeah, I just see less and less disease awareness education for COVID-19 and more in other areas, specifically with shingles and flu and RSV. So why do we not have this interesting question? Why do we not have long RSV, long flu, long adenovirus, etc. But we have long COVID-19.
I think we do have chronic infections from other viruses, but they just don't go on as long. I mean, just because you have an acute infection doesn't mean you don't have chronic, some kind of chronic inflammation afterwards. Immune response is the key there, and the immune response keeps going for a while. And in this case of COVID, we get mimicking, it would appear, of various antigens, and which allows the immune response to continue. So the viral infection is over, but then we have the problem of immune response continuing on, which is making people ill. It's not necessarily a virus question anymore, it becomes an immunological question. And people will be happy to debate that with me, but it's, I think, important to see it as two phases. And we know ourselves, if we have flu, we might recover in a week or two, if it's not too severe. But then you may not feel great for about a month. I think with long COVID, there's obviously a lot more going on. But we do have chronic symptoms after other viral infections for some time, including things we may not consider, like depression or feeling blue. And that can happen, that happens more often than we think, with people are feeling a bit down after getting an infection.
Question here from Satu Sa. She's asks questions nearly every month, so keep bringing those through. Are there any new variants? You kind of have touched upon this already. We're kind of chasing our tail with new variants. Are there any new variants of concern that have emerged since the last update, and how are they being monitored and managed?
Look, they've been monitored really well. There are labs around the world, as you know, who feed information into WHO, into the GISAID database and other databases. And those databases produce all sorts of lovely graphs and keep people informed on a weekly basis. If you're on their websites, if you're on their feed, and sure, we see new variants under monitoring, new variants of interest, and new variants of concern, but there are very few variants of concern. They're nearly all variants of interest now. So I really don't think we need to be concerned at this stage of any of them at all. At the moment, it's predominating, a JN1 is predominating, and there's a J1.4 and a 1.7 and a few others. And these will come and go. And, you know, I remember all the hype when Alpha, Beta, Gamma, Delta came along, Epsilon and a few others. Well, they're all gone. They've all disappeared. So even Wuhan's disappeared. So it's, you know, we're now dealing with the virus that's gone through the community, and the predominating one of the XBB group, of which JN and others, KP, are subvariants thereof.
So in 2021, 2022, I think a lot of the public that contracted COVID were dying from COVID. Are they now dying with COVID rather than from COVID?
Very few people are dying from COVID. The numbers are dwindling as the weeks go by globally, and certainly in Australia too. You know, we do have probably, we might expect 1,000 to 3,000 people die of COVID this year. We probably expect, 1,500 people, perhaps more, to die of flu. It's now dropped dramatically. And now people, as you say, possibly are dying with COVID and are dying of other diseases. But COVID is very serious in people that are immunocompromised or older, and it certainly needs effective hospital treatment. It's not to be trivialized in any way.
If a patient has myocarditis to an mRNA vaccine for COVID-19, should they avoid other
Yes.
vaccines for
Yeah,
other?
look, I think so. It's again, people will argue about that, but I think if you've had a second shot of an mRNA, you've suffered from myocarditis, then it's a contraindication really to get a third shot. So you should get a different vaccine. You could try a different mRNA vaccine, like Pfizer followed by Moderna. But you know, if you're a young person, it's an interesting question. You're at that tipping point, assuming you're healthy. you need to get a vaccine at all. If you're traveling, I think you should, but otherwise it's a 50-50 question in a way. WHO doesn't recommend it. And so the only other vaccine available in Australia at the moment will be a protein vaccine. You could try that. But again, the protein vaccine too does have rare instances of myocarditis and pericarditis. So it's a conversation they should have with their GP, talk about the risks.
With all these new variants, how sensitive are the rat tests now? Of course, these are operating.
Still, I'm surprised, to be honest, but they are seemingly pretty good still, as long as they're done properly. But they seem to be quite effective, all the rat tests. They, of course, have also been updated by the manufacturers. So the rat tests and there's influenza rat tests too now, and RSV coming if it's not out already. So these are important because then you can see what you need. You might need to take antiviral drug for flu, or if you're positive for COVID, you can then take steps to get medical advice or isolate yourself. Or if it's severe, you can go to hospital and so on and get treatment. But the rat tests, I think, are pretty good.
And there are accommodation rat tests now that cover, influenza and COVID. And I remember back, I had RSV and COVID at the same time. I just took a rat test for COVID and it came up, but it's probably a good idea to have a look at the combination rat tests. Here's from Rowena. What annoys me as a GP, we love these questions. Why don't medical specialists and hospital doctors recommend to patients and their families and that they get COVID vaccines?
Well, I'm not sure, but they should. Anybody working in a hospital should be recommending vaccines for their patients. It depends how sick they are, of course, and what they're treating them for. And it's obviously a clinical decision. But there's no reason why people shouldn't be getting vaccines, particularly if they're visiting a hospital and so on. You can also wear a mask and use sanitizers. All these things are effective, and it makes sense to take a vaccine because there's a pretty good chance you might pick COVID up at a hospital. Think of it that way. So, and you certainly don't want to see the virus into hospital. So these are the issues that people need to think about, and it makes sense if you're visiting people in hospital to be vaccinated. Really should have all your vaccines up to date.
We should. Just another comment from Rowena Ryan here. She's read that rat tests are sort of 66% accurate, or 3/4 accurate. So 2/3 accurate, but these are mostly because people don't use them properly. So just follow instructions.
Yes, no, that's absolutely right. They need to be used correctly, and some people just don't know how to use them, or they make a mistake, or they can't interpret it. Despite the instructions. PCR tests are still available too, but of course now you have to pay for them, and they are more accurate and more sensitive. There's no doubt.
Is long COVID accepted by the ICD coding and insurance companies for reimbursement? Do you know?
I imagine it would be. It's certainly globally recognised as a medical syndrome. So I don't see why not.
I'm still looking through the questions. Following infection with COVID booster is recommended for 6 months later. If high risk, would you recommend waiting 6 months or earlier?
No, ATAGI says 6 months. It makes sense to go 6 months. Antibody does wane at about 4 or 5 months and then drop off significantly, particularly in an older person, due to immunosenescence. But 6 months makes sense. It's something that's quite practical. We don't have waves of COVID infection in the community all the time. And although it hasn't gone into a seasonal pattern like flu has at the moment, I expect it will. But the virus is being reseeded into the country all the time from overseas. And that's why we're getting little mini waves and new variants that are coming through the population. But I think every 6 months seems to be a good measure. I wouldn't recommend any earlier. I think the ATAGI recommendations are right there.
Question from John. John Litt, can you please comment on the possible development of COVID vaccines that might provide some mucosal immunity and hence reduce the likelihood of getting infected and or transmitting COVID?
Yeah, I'd like to see more on that because it is a gastrointestinal virus as well as a neurotropic virus. It seems to affect every organ in the body. But many people do start with a GI infection, and mucosal vaccines we know can be very, very effective. So there are people working on live attenuated vaccines that can be taken orally that would then replicate in the GI tract and give immunity. So, but they're only in phase 1-2 studies as I understand it. But they're the only vaccines I know of that could work in that way.
So I've got a couple of more minutes still, sort of 4 minutes. A question from Paul: why does Australia's policy ignore the issue of pregnant women boosting and boosting healthcare workers?
Oh, well, it shouldn't. If that's the case, it should not. Healthcare workers need to be boosted for sure. They're a high risk group. They may not be at risk because of a medical condition, but they're a high risk because of the work that they do. So they should be offered boosters all the time, in my view. And the same with those people that are pregnant. I mean, there's a lot of fear about COVID vaccines, which has been trumpeted by misinformation on the internet. It's very unfortunate, but we need organisation like ours and GP networks and infectious disease networks. We need to counter that disinformation and start promoting vaccines. They're incredibly safe in pregnant women. There's absolutely no doubt. And people that are falling pregnant or plan to fall pregnant or breastfeeding can all safely get the vaccine, whether it's mRNA or protein. There's no doubt about that. The science is quite strong and clear, and the message needs to be put out there.
There are a few controversial questions in here with Wuhan, which I think I'll skip. Any more questions that someone wants to push through?
Well, if there's questions on the origin of the virus, that's not something that can be answered. I mean, people are very divided on this, but I would suggest we wait and see as good scientists. Let's wait for the evidence rather than speculation by news reporters. Let's wait for the evidence. But every other pandemic I've looked at has always been a spillover from animal into the human population. This is common, this is normal, and this is why I expect is the case. But the jury is out, and we'll just have to wait and see if there's any further evidence on both the lab leak theory and the spillover theory. And it's not worth speculating on.
Do you think combining COVID and influenza vaccine into one vial will significantly increase the vaccination rate, particularly when flu vaccination rate is particularly low on its own as we lead into the winter season?
Well, I'm assuming that flu would have to be an mRNA vaccine. I might be wrong there. But if they're both mRNA vaccines, that'll be interesting. We need to see the data on that. There is no registered flu mRNA vaccine. So, but I know that Moderna have been looking at making a or combination of flu and COVID, as well as a combination of flu, COVID, and RSV. And it's theoretically quite possible, but let's wait for the data and the studies. And we'll see what the immune response is like compared to the current egg-based and cell-based vaccines that are being produced for influenza. So at the moment, you can get them concomitantly, have mRNA in one arm and flu in the other on the same day. But people do that. It seems to be quite successful. I'm not sure if they have to be a significant study, I think, for an mRNA and a kill vaccine to be combined together in one shot. I think that'd have to be both mRNAs.
Okay, look, I think we're going to wrap it up at 7. I'm conscious of time, and it's everyone either has to go home or they've got to start dinner for the family. So could you just go to the next slide then, Gary? I think there's one slide left. No, there's no slide left. Okay, all right, well, I'll just say it manually. So thanks, Gary, a wonderful presentation. You've put a lot of effort into that and it was very thorough. So thank you also to the audience for all your questions. For those questions that we didn't get to, and there were some, we'll look at those and provide a response back to you within 7 days, together with a link with the recorded presentation. I'd just like to plug a couple of up-and-coming events, and that is the webinar 2 of a 3-webinar series that will be next Wednesday on the 22nd. That's on flu, COVID-19 and RSV. It's a 45-minute panel discussion. There are no slides, so it's a multidisciplinary expert panel discussion. So that'll be on our website, so please have a look on our website under events and you can have a look for that. And also on the 26th of June, we will have a physician talking about RSV as an RSV update. And lastly, on the 14th of June, which is a Friday, post CDIC meeting, we have our annual immunization forum meeting on the Friday, on the 14th. It is a hybrid meeting. Not everyone can get to Brisbane. It's at the Stanford Hotel. All the details are on our website. But it is a hybrid meeting and you can go online and register, and it is a free event. And this year we're moving away from disease-specific presentations and we're making them more practical specific for GPs and pharmacists in the areas of, delivering vaccines effectively in primary care and pharmacy, targeting and delivering vaccines to high-risk groups, vaccinating into nursing homes. So moving away from just what's an update on specific diseases. So putting more practicality around that, and particularly one topic, which is a first for us, is protecting First Nations people, addressing the gap. So wanted to get one of those talks into our into one of our events from now on. So with that, it's just after 7 o'clock. I'd like to thank everyone again. All these presentations will be on our website in a week's time, and look forward to seeing you again in the coming weeks. So from Gary and I, it's a good night. Thank you.